Good, thank you.
Thanks for taking the time to do the interview with me.
Pleasure.
I guess to start, just tell us a little bit about yourself and what you do here at Maroondah Hospital.
Sure. So my name's Will. I'm a geriatrician. I've worked here at Eastern Health for a long time, like 17 years or something like that. And what do I do? So I'm predominantly involved in the care of older patients, which is a lot of our patients, isn't it? It's a large percentage of admitted patients, certainly, to the hospital, elderly people. And I do a mix of things, including some acute medicine, but predominantly I'm looking after people in a subacute environment. So these are older people who've been admitted with strokes or heart attacks or illness, infections, fractures, and who have become deconditioned as a complication of that admission and require time to recover physically, cognitively, medically from their illnesses. So that's predominantly what I do, a little bit of community work, older people.
Yeah, that's good. Thanks for telling us that. I guess in terms of blood flow restriction training and knowing how it works, what are your thoughts on this method of training?
Yeah, look, Stephen, I was really interested when you mentioned this to me. I had heard of this, I think, in the context of athletes training and preparing and trying to maximize their physical strength and endurance. So I was aware of the concept, but I have to admit it had never occurred to me that we could be applying it to our patients. So I found it very intriguing. And I think doctors in general tend to be a fairly conservative lot. So you're always cautious, but I think it's an exciting cautious, because I think an intervention like this has the potential to improve patient recovery, and especially when we think about what we're doing in our subacute units, like the unit we're on currently. We have these frail older people who have issues with muscle weakness and muscle loss. Any technique that's going to help us to either maintain or improve their muscle strength and endurance is going to have a substantial impact on their admission. It may reduce the risk of falls, and you could conceivably shorten elective stay and return them home, which is of course what they all want to do. So I'm excited by it. I was intrigued, and I think it's a good idea.
I guess knowing some of the common side effects of this technique and the contraindications, do you think that could, still be implemented into like a hospital setting?
Could you do it? That's a good question. So, at first blush, I think the things you'd be cautious about would be the people who have very poor skin condition. And of course, some of our patients have very thin and vulnerable skin. You can sort of tear the skin with just gentle knocks and bumps. So those patients you probably want to be cautious. That being said, often that skin thinning problem is not everywhere, so it's quite conceivable that they'd be able to apply, say, these pressure garments to the legs, whilst we have to avoid the arms. So I think there was that thought that crossed my mind. There are people with peripheral vascular disease where the perfusion is compromised. Anyway, and of course you'd be careful in those people. It's actually fairly uncommon though, and I suspect if we were to inflate a cuff on somebody who had peripheral vascular disease, which we didn't know about, the likelihood that person would get a limb-threatening ischemia simply from the device before we noticed there was a problem would be pretty unlikely. There would be the potential issue, and I think we discussed this earlier, of thrombosis. It's possible, but you're exercising the patient, and I think the major threat with thrombosis is stasis. It's the patient who's not moving at all who gets the clots. It's not the ones who are moving. So I think whilst you'd be cautious in certain patient populations, I certainly don't think that would necessarily limit its efficacy. And the really important thing for us will be how helpful is it, if we're doing this, and that of course it's exciting potential. We'll need to see over the course of studies as to how much improvement we can expect when we use this technique. But I think
that makes sense. And I guess in terms of what you mentioned as well, if we did try and implement this in a hospital setting, that would probably be more MDT involved as well, so involve like VOT potentially for like pressure sores, and the doctors obviously
Yeah,
yes. Use.
I think absolutely. So I think if you were trialing it, you would certainly be very vigilant for any potential problems that arose. You'd probably, ideally, you would try and provide some sort of placebo control to it, wouldn't you? And the way you might do that would be different options. I can imagine. Well, one would be doing the physical therapy without the aid of the cuff, and the other would be doing sort of a sham blood flow restriction device, which just didn't apply enough pressure to restrict the flow meaningfully and compare them. But yeah, absolutely. I think technically executing that process would require careful vigilance and observation, but it'll be exciting to be part of that kind of project, I think.
Yeah, and I guess in terms of the device, it could be a little bit expensive sometimes, but do you think in terms of using the device in a hospital setting, it would be worth trying?
Well, I think one of the things that isn't always appreciated is how expensive healthcare actually is, especially in a place like Australia where it's subsidised or paid for by publicly in many situations. So when I consider how much we spend every day on routine investigations and evaluations, the few $100s it looks like it would cost for a reasonably good quality blood flow restriction device actually doesn't seem like that much.
Yeah.
I mean, chest X-rays could easily match the cost of one of these. A couple of chest X-rays and some blood tests, you could match the cost. And if you consider that if it's efficacious and if this meaningfully shortens people's stays in hospital, improves their outcomes, the cost savings from it potentially could be dramatic. I think we discussed that too. I think even if you save a day's admission to hospital, you're probably saving between $1,000 and $1,500 in a subacute ward. That's a lot of money.
Yeah, it's pretty considerable.
You could buy a few.
You can probably buy 3 of them.
You could buy 3 of them. There you go. So it could easily pay for itself very quickly if it shows efficacy, and of course that would be what we'd be looking to see in a study in a clinical setting, wouldn't it?
Yeah. Perfect. I think that was all the questions.
Sure.
I really appreciate you taking the time to talk.
It's my pleasure.
So
excited to see where this ends up.
Hopefully we'll be able to use it. Who knows?
I hope so.
Thanks so much.
Thanks, Steve.